Good morning, everyone. Welcome to the American Enterprise Institute. I'm Tom Miller. Welcome to our discussion this morning on closing the gaps in health outcomes. This is a little different approach to healthcare and health policy in Washington. You actually have to think about what works as opposed to what you've been doing before. It's been attempted on occasion, not that often. Let me give you a little bit of a very high-level, oversimplified, exaggerated overview. Our purpose today is to think about health outcomes, not just intentions, not just we tried to look at what we threw up against the wall, but what actually began to perhaps could make some differences in what should matter in our health policy and healthcare system, whether people are actually end up being healthier. We do a lot of other things said to move in that direction. And we want to take a look at this from a longer time horizon than the standard Washington cycle of it's 2 years to the next election. We're already campaigning, so if it doesn't pay off right now, I guess it really doesn't matter. There's a longer life that most of us lead as opposed to the political lives that our office holders have, and we might want to think about what actually matters over that long-range perspective. And also to think about we know that health care, health insurance coverage, all the wonderful things our system can do in treating people who are already ill is important and it's necessary, and we've made some steps to improve that. Mixed opinions on that, but it may not be sufficient in order to actually get the type of progress we're seeking. And we've got a long trail of evidence on that front. So it's not just a matter of more, let's put some more things on top of the pile. Don't take anything off, but perhaps a look at some better trade-offs, at least on the margins, because although we'd like to imagine that resources are unlimited for a good cause, they turn out to be a little constrained. We need to think about what we're getting for what we're investing and what we're doing. What we're going to talk about today are some promising areas of some other directions or better directions to pursue more aggressively. It's not an exclusive list. There's a lot of other good ideas and things to do, but these are a few that we want to highlight today that perhaps haven't gotten the emphasis that they deserve. So in that regard, we're going to take a primarily look, and this is oversimplification, of about three alternative paths forward. The first, for want of a better term, is the impact of early childhood development on not only your current health, but long-term adult health. And there's a lot that goes into that. It's more than just standard childhood development, a lot of science behind it, but that's the broader framing perspective on it. Now, that's a lot of the focus on the front end, which is what we can do in the future and how we're building a base of healthier people. Well, we've got a lot of people, though, who are currently in the system, different ages, different conditions, and you can't just say, well, sorry, you came too late, we'll just start all over again. So what do we do about improving the actual performance of the system so it begins to communicate and talk to and serve the people it's supposed to be serving, which is the focus of another presentation on, for want of a better simplified term, patient navigation. Not how do we find someone to sell you a health insurance policy, but actually connect you up with the resources in a very complex and expensive system so that you're not just bobbing around in a lot of disconnected parts of a system where they don't talk to each other and people aren't all focused upon how is it best focusing upon what the patient needs and what can best serve them. And the third area, again, there's more involved in this, but we'll use the broader term of behavioral economics. What goes into health behaviors, shaping them, the various, if you will, psychosocial skills that go in shaping that. And there's a broader perspective on that. But that's kind of the overall look at this. And all this, we're doing this from the framework of it'd be great that this works for everyone and across the board and we're all coming out ahead, but particularly paying attention to, in our healthcare system, how the broad term disadvantaged population, which covers a lot of territory, who's most vulnerable and who gets hurt the most under the current way of doing things, how can we help them more? So let's put a little context on what we're talking about. Promising more of the same is not surprisingly most likely to deliver more of the same. We've done that before, we're doing that currently, we'll do that again, but we're trying to stretch beyond that. We're also going to take a little bit look at it, in the time allowed, a bit more of a multidisciplinary science of human development. A lot of factors go into not just whether you've got well baby care, but how that child ends up developing and growing, and all the different things we're learning in a much more sophisticated way about how the brain develops, how that affects the rest of the body, your health, the whole environment in which someone grows into their adulthood and what goes on. And a bit look at, although we have a lot of phrases, well, here's the basic policy point. If we can think about early prevention, not in the standard way of I bagged and tagged you and you got the required test, but prevention, which actually means that conditions that might otherwise occur don't occur before they have to be treated. You actually reduce the demand into an expensive and complex healthcare system. That's a different approach than what we've done traditionally in the United States, which is later remediation and treatment, fix it again and fix it again some more, which we can do sometimes very well. But wouldn't it be better if we didn't have to only resort to that at the back end stage of what we try to throw money at things in order to correct what wasn't done earlier? Also to take a look at both the whole child in all of its dimensions and the whole patient. We tend to look at fragments of these things. If there's not a billing code for it, sometimes perhaps it doesn't look into a larger integrated manner. And then to look at improving risky environments and helping fractured families, to take the American population as it is rather than as we imagine, but there's some people who need a lot more help. And how can you reconnect those broken pieces at an earlier stage? And then within the realm of what's reasonable and possible, sometimes you can overpromise, and this is more of an integrated care approach for more complex clients. Now, this all sounds wonderful, and then you have to face actual evaluation. So what are some critical questions behind all of this? You can sketch out a theory, but you have to face some harder questions. Is there real evidence for what might work and how effective it would be? What are some metrics of success? What impact are we looking at? What's the time frame, the net payoff? Some things can deliver something right away, very visible. Others have not only longer-term latent effects, but perhaps cumulative, where what you did at an earlier stage begins to pay off on a longer time frame than what you first see right over the horizon. Are a lot of these ideas and concepts and programs, are they scalable? Can you go beyond what works in one place to somewhere else and replicate it and produce it on a larger scale? The trade-off, though, is that you start saying, well, this really is great, so we're going to do it for everybody. There's a degree in this field of a little need for some customization, some localized approaches to things. So you can't just say it's, here's my evidence, boom, we're off with a kind of a national program. And that's the trade-off between things that are sensitive to the community-based resources and values in which they're operating, as opposed to got a problem, got a national plan, got a program, we're off to the races. So is things going to be universalized? There's always a temptation to say, since this is so wonderful, we'll do it for everyone and everyone will be happy about it. Or is there a need to be a little bit more targeted? Or as an intermediate step, perhaps making things available to everyone, but recognizing that other people need special assistance in getting access to them. That's more of the sliding scale subsidy approach, although we can stretch that to where it looks like it's the same thing as a universal program. Okay, so some dangers and pitfalls in going down this road. Let's talk about our political system for a minute. It's hard to get success in Washington for a good idea unless someone can gain political credit for it. So you have to dial in the office holders and say, oh, you thought of this, thank you very much. And you can kind of put your stamp on it. That's the tendency to say if you can't put it in legislation or have a subdivision of a departmental program with a funding stream, it doesn't really exist, even though these things are much more attenuated and indirect, perhaps, than the standard cookie-cutter Washington approach. There was a paper I recall looking at the health policy of the 1990s by some esteemed researchers, and one of their subtitles was, this is the Clinton days, feeding the middle class. I would add feeding the middle class first, feeding the middle class most, feeding the middle class most visibly. That's unfortunately our political formula, even though it tends to overlook the individuals who need the most help. And it's not the same thing as if you do something for everyone, you may not be doing very much for anyone at all, wide and thin approaches. But that's another set of trade-offs in the political marketplace. Overgeneralizing and overprescribing, we've seen that before. Things that can work well and be promising in one context may not necessarily be the same everywhere, so you have to kind of respect some of the limits. And diminishing returns. What may be very good in one application, if you keep doing it, may have diminished returns, or it may apply to a particular population at particular times, but not necessarily having the same equation at different points in the life cycle. Another problem is, what do you do about the installed base, as I referred to before? I usually get this in computer terms, but there are just a lot of people who are moving up the age scale who already have their chronic conditions. They already have their medical conditions. So it's not just a matter of saying, you'll never get sick because we did these things. So you have to think about other ways in which the healthcare system can adapt to them, or the fractured families that need to be reconnected, as opposed to starting from the beginning. We have a little bit of a condition that's been diagnosed more rapidly, political attention deficit hyperactivity disorder, where we get real excited about something for a brief period of time and wave our arms and then move along and forget about it. We need a little more patience and a longer-term look at this. Reimbursement food fights will, of course, be prevalent here. If you move some of the dollars from where they currently are to somewhere else, there may be a few cries for saying, oh, we do that too. We have a billing code for that provides the same type of services. I've seen discussions of pediatric medical homes. I'm waiting for a prenatal medical home coming next. Probably have ACOs for particular disadvantaged populations. There's a tendency to redefine things to say, we actually do that, we can get the money as well, as opposed to what might be a fresher look at this. Sensitivity to cultural norms and parental prerogatives. As wonderful and excited as we can be about how a particular intervention may work, we need to remember that just imposing it from the top down, knocking people aside, saying we know what's good for you, we have a better idea as to how to parent your child than you do. There's some boundary lines here. You want to be careful about how you cross them and how you do that in a much more sensitive manner. You can break things while you think you're fixing them. But in all of this, the more important thing is you can be paralyzed by all of the what if, and you haven't shown this, and it could happen like this. Let's get started and adapt along the way to actually do something by doing more of it and learning as opposed to it being a settled equation. So I learned in a presentation a long time ago from someone else about how you actually make something work in Washington. There was a standard version. First, you have to have some enemies, you have to have some allies, you have to have some anecdotes. But one of the most important things in a program is you have to have a slogan. You actually, if you can't simplify it on a bumper sticker, you've got to put it right up there. So I'm going to give you a couple of slogans that might work for this. Some better, some worse, some visual, some not. We want to talk a little bit about tactical myopia, that we might only be able to see what's right in front of it and might need a little corrective lenses in order to see the wider field on a longer range basis. Some other slogans. This is the Fram oil filter TV commercial a long time ago. You can pay me now or pay me later, with the mechanic coming out from underneath the car, suggesting that perhaps what seemed like economizing measures initially end up being more costly later. Sometimes it's good to invest in something for what it returns later. Actually, in I think one of Gabby's papers, not quite a ringing phrase from redistribution to predistribution, although it actually deals with the content as to how we change the way in which we help out people who are going to fall behind unless they're given some assistance. From the field of baseball and Yogi Berra, it gets late early, which was originally referring to the shadows at Yankee Stadium in the fall, but it also means that a lot of the things that we miss out on in terms of what could be ways to improve people's health, if you don't do them early, you're going to pay for it later on. Patient-centered is one of those overused, wonderful phrases that perhaps has lost meaning by being used too much. And we're here to help. It's already run into some problems with governmental sources, but there are some people who are here to help, and we need to think about how they could help more effectively. So, more visually, we want to break down and reconnect the silos so that they're not all the different bunkers and programs of our healthcare system which don't talk to each other, and integrate in a way in which they're dealing with the entire patient or the person in front of them. Is there light at the end of the tunnel? This actually is not William Westmoreland in the Vietnam era, but it was Robert Lowell, because he asked, is it just an oncoming train? So we think there is some light, but you can dodge some obstacles along the way. And finally, a couple other things going way back in time to a long-running TV game show, Truth or Consequences. That was actually Bob Barker's big show, and he's still alive today, by the way, I think in 91. But this was the idea where they would start out by saying, they'd ask people a question. If they got it wrong, they'd have to do some zany stunt. That's pretty much what we do in our political system. However, the other idea is if we don't begin to deal with some of these truths, we're going to continue to suffer the consequences. And in the larger scheme of things, although we've had some progress in our healthcare system, healthcare spending, blah, 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 where it's not as bad as it was, we still got a lot coming into the system. We're going to need a bigger boat in order to have some other tools. So with that rather light introduction, let me introduce a couple of our speakers for our opening set of presentations. This is focusing upon early childhood development. As I scramble around, we have Dr. Frances Campbell, who is a senior scientist at the Frank Porter Graham Child Development Institute at the University of North Carolina in Chapel Hill. I mentioned Barack, who's another speaker from North Carolina, from Duke. This is the only nonpartisan peacemaking effort where we can unite both UNC and Duke on the same panel without any major conflagration occurring. If only they could learn about this in the Gaza Strip, we'd have a safer world all about us. Frances is internationally recognized for her work on the Abecedarian project, which is one of the longest running longitudinal studies in the world. And she was there from the very beginning, working with a group of infants in 1972, and her and the other folks in that project have followed those children as they've aged into adulthood with some remarkable findings about what the effects are on their broader lives, but also their adult health. In a more recent article in Science magazine with Gabriella Conte and several other co-authors, I think those findings are quite remarkable and tell us a lot about what we can learn from that. Frances has also conducted research on how children in Head Start programs make the transition to public school. She served as a member of the White House Conference on Early Literacy and was a member of the Pritzker Consortium on Early Childhood Development, and she received the 2007 Alumni Distinguished Service Award from the University of North Carolina, Greensboro. Now, I mentioned in passing Dr. Gabriella Conte, who was co-author on the article in Science, but also a wide range of literature in this field. She's an assistant professor in the Department of Applied Health Research at the University College London, faculty research fellow at the National Bureau of Economic Research, research affiliate of the Population Research Center at the University of Chicago, and a host of other affiliations. I'll compress them right now. But what's remarkable about her work is how it draws upon such a wide range of fields, biology, genetics, epidemiology, neuroscience, medical economics, and the economics of human development. And she's developing an integrated developmental approach to health from before conception and is modeling the economic, social, and biological mechanisms that produce health inequalities over the life course and across generations. We have two other speakers as well, but we'll start at this point. We'll open with Dr. Campbell, and then Gabriella will complete the presentation, kind of a joint production. Dr. Frances Campbell first.
Thank you. Well, let's see. The Abecedarian project began, as he said, in 1972. It really was a multidisciplinary study, so when I say it didn't have a medical focus, that's wrong. It had two primary investigators were a developmental psychologist and an educational psychologist, and that was the psychological part. The other three investigators were all doctors. And so from the get-go, the children in the treated group got their primary care at the center and were closely followed medically. They were primarily looking at infectious disease kinds of things. That part's not a randomized study. Our part, the psychological part, was. I'll go very quickly over this war on, the problem of poverty, and poor kids are in trouble, and we all kind of know that. The war on poverty had just happened, and Head Start had just happened, and everybody was so excited, and then everybody was, oh no, Head Start washed out. What happened? Maybe we did too little too late, and this was, can't hear me? This worked to the advantage of Craig Ramey, who was really interested in contingently responsive environments for young kids, and he really wanted to see what kind of difference you could make if you really started with very young children. And as Gabi will tell you, there's a lot of literature that talks about the importance of very early in the lifespan. So Craig wanted to see what he could do with very young children, and broadly defined, the Frank Porter Graham Institute at that point was an MRDD study, and so the prevention of mild mental retardation, which is more prevalent in kids from low backgrounds who don't look sick, I mean, they don't have some obvious syndrome. So that's the kind of child that we were targeting to find. The focal question, and let me get to my focal question. Could we prevent this progressive decline that seemed to cross-sectional research indicated that kids from poor backgrounds look pretty good as babies, and then if you get standardized measures on, even though they don't see anything wrong, they just go down, down, down. Could you prevent that if you started early? So that's what we did. The target population, this is not a huge study. And we started out, we had about 122 families that agreed either at the Department of Social Services in the medical school, yeah, we might be interested in talking. 120 of them actually came in, and I interviewed the mothers and gave them a test. Of those people got random assignments. At that point, who turned us down for the most part were people who got the treatment because they did not want their infant in full-time care. So I won't go into more than that, but we ended up with 111 babies born to 109 mothers. 98% of these children are African American. That's just what happens if you're poor in Chapel Hill, North Carolina. So this is our study design. We had a pool of subjects, and they're randomly assigned to be either in the treatment group or the control group. And this summarizes the early experience of those children. You can see on the right side what the treated children got. They were in full-time, all-day child care. We quickly found out that if we didn't go get them, most of them couldn't get where we were, which was not walking distance from where most of them lived. So we brought them there, and they were there for the first 5 years of their lives. And I think that's probably critical because they knew where they were going to go, and they knew who was going to be there when they got there. The staff was very stable. In order to have people not say, well, you made the kids look better just because you fed them better. For the first 15 months of life, the children in the control group were given iron-fortified formula as much as they could drink. We stopped it at 15 months because the dentists were concerned about their teeth. The kids at the center got the same stuff. They got 2.5 meals, 2 meals and a snack every day. I said they were in a stable environment, knew who was going to be there. The kids in the control group, varies and sundry. They weren't all home with mom, but they probably had a lot more variety in their daily lives. Primary pediatric care on site. I said there were 3 doctors involved. So the children in the treated group had their primary care there. And they were monitored daily. And I think our best carrot for the control group is they got free disposable diapers. Okay, the major outcome, because we were looking at intellectual development, was performance on standardized tests, and here's the bottom line for the first 5 years. You can see the red line is the control group, and look at the very first thing, that's 3 months, and the kids are right on top of each other. They really were not different at the beginning. By the time they're 3, they're maximally different. And I'm going to hurry here. This is what happened after that. This is when they entered public school, we created 2 more randomized groups. The top group got 3 more years of early intervention in public school, and the second one down just had the 5 years and no follow-on. Then the control group, half of them got that 3 years in public school, and then we have the untreated. And that program lasted 3 years till they were 8. I'm not going to talk much about that. We followed them up when they were 12, when they're 15, when they're 21, when they're 30. And every time we did that, we were looking at the random effect, the randomized groups, and we're primarily looking at cognitive development and as they got older, what kind of academic performance they had and what kind of jobs they had, what kind of education they attained. That's the IQ trajectory up to age 21, and the point of this is it's very large in the early years when they're being treated. It goes down considerably from that when they get into school. But the point is they never converged. You could have knocked me over with a feather when I thought they'd be on top of each other at 21. I really did. They aren't. Okay. I'm going to tell you a little bit about what they were like when they're 30. I think 30 is the right time to tell you because if they were going to college, they were out of college. So we can look at graduation rates. This is the educational attainment. It's statistically significant when they're 30 years old. It's not huge. It's about 1.5 years more on average for the treated groups, but this is my favorite slide. This is college graduation. They were 4 times more likely to have graduated from college if they were in the treated group. Now, those are not huge numbers because by the time they're 30, I said we started with 111 kids. By the time by the time they went to school, we were down to 105. At 21, we saw 104 of that 105. At 30, we got 101 of them. And so our attrition has been really, really good up to that point. But how many of them graduated from college? 15. 12 of them were treated. Only 3 in the control group made it. And the other point I want to make is that if you look at the treated kids who graduated from college, the males were just as likely to get out of college as the females. However, we had 3 people who had gone on to do some graduate work, and all of them are girls. Let's hear it for the girls. This is the income to needs ratio, and this frustrates me considerably because it's in the right direction for treatment, but the income just by itself didn't make statistical significance because the distribution is too broad. We had some pretty good people in the control group and some pretty, anyway. Full-time employment, that is significant. We went back for 2 years, and to be counted full-time, you had to be working 30 hours a week. They were significantly more likely to have been working full-time if they had had preschool treatment. Remember, they're 30 years old now. Need for public welfare, that's a whopping difference. Not that many of them were on welfare, but the probability that you would need it is much, much greater if you had preschool treatment. Didn't have preschool treatment, she said. Okay, now the other biggie for early childhood education, if you listen to the preschool stuff, is the reduction in crime. How did we do? We didn't. We simply don't see that in the Abecedarian study. This is self-reports, and it's in the right direction, but it's just minuscule. And we have actually searched criminal records too, and it's the same story. Okay, the point of this slide, and I'll say it really fast, is that the home environment still mattered. It wasn't that the quality of your home environment was irrelevant if you had treatment. We would totally make up for that. But what you see is that if your home environment's really poor, and what we're modeling here is education at 30, how far you got. If your early home environment was really poor and you're in a control group, you really didn't get very far when you're 30. But if you'd had early treatment, you're almost as well off. But you can also see, if you look how it plays out, when you get to the really good home environments, the really good home environment adds on. So it's not like we totally replaced what the family brings to the table. I want to make that point. Let's see. Now we come to our latest claim to fame, which was a challenge grant. here was a chance to take a randomized look at the health of these people. The early doctors did tons of research and lots of publications, but it's sort of correlational, what went with what, because we don't have the kind of medical information about what the control kids, how sick they were, where they saw doctors and all that kind of stuff. So we got a challenge grant to send everybody to the same doctor for a physical and to look at the results of those physical exams as a function of whether or not they had the early childhood program. So we got the money, we collected the data. We had our worst attrition problem ever. We had 12 people in both groups who were eligible, and we found them, and they said they didn't want to do it. And a lot of them were afraid to go to the doctor, and they just didn't. Some were very busy professionals working away and didn't have time to stop. Anyway, we had more attrition. The bottom line is of our 111 kids that we started with, we only got 78. That said, we found a significant difference in their health as a function of early childhood intervention. When they were 0 to 5, we know that they were in full-time child care, educational child care. And we know it made the kind of difference in cognition that I have said. It also made a difference in their health, and I'll let Gabi tell you what. Oh, wait, let me flip. Here's my acknowledgments. Those are the names of our famous START people. You'll notice I'm down there as the evaluator. And these are the people who worked on the challenge grant. And these were our funders. Thank you.
Thank you, Dr. Campbell. There was a conference just last week, I think, on healthcare spending where Alice Rivlin of Brookings, who's co-chair, I think, of the RWJ Commission on Healthier America, said if she heard one more, mention of the Perry Preschool Project, she'd scream. And I was listening in the distance. I don't think her ears are tuned to the ABC project, but this is important findings and kind of adds to the compilation of research in that field. And our next speaker, who will flesh that out further, is Dr. Gabriella Conte, who I would recommend you look at some of her published work because it's quite impressive in this field and it extends over a wide range, but she's going to build upon this in a developmental approach to health policy.
Thank you very much, Tom, for the introduction. I'm very pleased to be here. So what I'm going to do, I'm first going to talk about a general developmental approach to health, which is focused on prevention rather than treatment. So it gives you a different view of approaching health as compared to what is currently done in medicine and in the current health policy. And then, as Frances mentioned, I'm going to go into details of the health effects of the Abecedarian intervention. So what is the motivation for doing this kind of work? So we know by now there is a lot of evidence that early life conditions matter for health and that many countries, both developed and developing, pay the most of the healthcare cost in non-communicable diseases. But now we also know that while current interventions focus on trying to remediate these conditions in adults, these conditions are at least in part preventable. And lots of evidence, and I'm going to go through part of this evidence from the biology and the medical sciences, tell us that we can actually do something before disease occurs, at least to delay its onset. So this is why developmental approach to health policy and to the reduction of health disparities is very promising, but at the same time is very challenging because there is still so much that we don't know, but we do have some very promising evidence. So in this talk, I'm mainly going to address 3 questions. So one, when health inequalities emerge and how do they widen throughout the life cycle? 2, what are the mechanisms through which they are transmitted, both social and biological? And 3, what are effective interventions to promote health and prevent disease? And of course, these questions are very important both for policy and for science. So let me start with a simple graph, and you probably have seen many variants of this graph, which is just showing the differences in many measures of health behaviors and health between more or less educated individuals. So the size of that bar just represents the difference, for example, in smoking behavior between more and less educated individuals for both males and females. And this is just showing something which we all know, that more educated individuals are likely to be in better health, they engage in healthier behaviors, they also do well under a variety of other aspects of their life. And now the key question is, okay, what do we make of this? Does this tell us that education policy can be a good health policy, or are these actually differences? Do they come from somewhere else? Do they come from earlier in life? Do they come from other factors early in the life of the child? Well, in work that I've done with James Heckman at the University of Chicago, we have actually decomposed these gaps. And if you look at exactly the same bars, you see that the white part of those bars represent the portion of health disparities which can be attributed to early life factors. So what I'm going to go through now is basically what are these early life factors, how we can boost them, and actually giving some evidence that intervening then reduces health disparities later in life. So when health disparities emerge, we actually know that there are differences emerging since very early, since birth. Well, now we know that they actually emerge before birth. So if you look at these pictures, this comes from work that I'm doing with pediatricians in Southampton, and this shows differences in anthropometrics of the fetus in the womb at 3 points during gestation. And the size of the bar represent the differences in the head, the femur, and the abdominal circumference of the fetus between mothers who smoke and who do not smoke during pregnancy. So what we see here, we see the significant differences by background characteristics are present since the first trimester of gestation, and they do widen already while in the womb. So it's not surprising that then we see them at the birth. We see gradients in low birth weight by social class. We see them widening up throughout childhood and adolescence. This is from a very famous paper on the widening of the income health gradient. And then if we don't do anything, we just see them reflected in adulthood. So this is differences in C-reactive protein, which is a measure of inflammation by parental social class at birth. And we see exactly the same gradient that we've seen throughout. So why those differences widen up throughout the life cycle? What is the way in which we can think about this, and what is the way in which we can think about devising interventions? So of course, if you're thinking about life cycle, you do need something like a Lifecycle Framework. And so what this framework here does, it basically shows these capabilities of the child, which are on the right part, these thetas, which we can think very easily of them of traits like cognition, personality of the child, these behavioral traits, his health. And the point here is to show that these traits are actually not fixed in stone, and they're not fixed at birth. They do develop throughout the life cycle. And then, I'm not sure I can really point here, but you see that there are these arrows. So they actually do boost each other. They are self-productive, and they can be affected by investment. You see these eyes in the second column, and then by parental traits and environment. So there is actually something we can do about them. Now, why do we care about these traits? Because these were behind those differences in health disparities that I showed you in the previous slides. And we do have a lot of evidence that these traits of the child, which develop throughout the life cycle, matter for health outcomes. So here, I'm just summarizing a bit of the literature, and especially in economics, which has shown that capabilities of the child, like cognition, behavioral traits, personality, health, both physical and mental health, are strongly predictive and cause late behavior and late health. And let me give you a little bit of more specific evidence from my own work. So what I'm showing here, I'm showing the effects that improving traits of the child. You see that along the x-axis, there is the percentile of the distribution of the traits of the child. So when you move from the left of the right, you're actually improving the child, moving him up along the distribution, cognition, self-regulation, and early life health. What is the effect that this has on late life health behaviors? So in this case, we look at the effect of improvement of these traits of the child on the probability of being a smoker at age 30. And so if you look at the red line, you will see that if you move a child from the bottom to the top of the distribution of self-regulation, so you increase its capacity to regulate his life and his behavior, then this child as an adult will be much less likely to be a daily smoker. So intervening, boosting these traits of the child have actually consequences in terms of late life health behaviors. And let's think of another outcome. Let's look at the probability of being obese again at age 30. So in this case, that blue line is the physical fitness of the child. So what does it mean? That if we have an intervention which actually improves the physical health of the child, moving him from a very unfit child to a fit child, this is actually going to lead to a reduction in probability of being obese at age 30. And keep these two in mind, because these are actually two traits which can actually be boosted by intervention. And I'm going to talk next about two interventions which boosted these traits and caused a comparable improvement in these very same late life outcomes. So how can we improve these traits? As I said, part of them may be genetically inherited, but part of them can be improved by investment and environments. And again, there has been in the recent years a lot of literature showing that inputs in the production of the traits, the development of the child, is actually both short and long-term effects on health. And you might have heard a lot of time, talking about stress, adversity. So that's, I think, a very general definition, while it's more instructive to think of them in terms of specific inputs that poor, disadvantaged children might be lacking, because their environments are not very rich. But then if we can enrich those environments by providing these inputs, then they can have an effect on health. And again, I'm going to give you evidence of interventions which actually provided at least some of those inputs, and they had health effects. And here, a very, very simple and very instructive characterization could be thinking in terms of attachment, providing the children stimulation, good nutrition, and of course, healthcare. As we heard from Tom, it's necessary but not sufficient. So just let me give you another example on one of those inputs from other work that I've done, and this time not on humans, on monkeys. And you will see immediately why this is done on monkeys. So this is a work which is aimed at understanding what is the importance of early life attachment, and in particular, what is the importance of having a mother in the sense of having some form of warmth from a human being who cares about you and is there for you when you need it. So what this experiment does, in this experiment, monkeys are randomly taken away from their mother since birth. So there is a group, which is the one where you see the picture on the left, which is called MR, mother reared. Those are monkeys reared with their mother since birth. So think of children being reared, with the mother or with a nice, attentive caregiver. Then the ones in the middle, the PR, are the peer-reared. So these are monkeys taken away from the mother since birth and reared with a group of peers of the same age. So think of these as children raised in the orphanages, so children without a good caregiver, who basically have to take care of themselves. And the last one on the right are the SPR, the surrogate peer-reared. So these monkeys are basically left with this hot water bottle hanging from the cage. So you can think of these as basically the worst form of maltreatment and neglect that children can have. So what actually we can do with this data? We have looked at the health consequences of being reared without a form of secure attachment. And what we've found, perhaps not surprisingly, is that especially for males, there are both physical and mental health consequences. So if you look at the bars there, you see that the monkeys reared without any form of maternal or social form of warm attachment, they develop physical health conditions. I could show you the gradient in mental health that's even more striking. And these conditions they do not disappear once the monkeys are put all together and they are taken away from these different rearing conditions. And so one question is, of course, how these conditions affect the biology of the body and then affect their health. So in these cases, in many other cases, it actually works through the stress response system. So the conditions outside the body determine changes in the stress response pathways, so that children who are raised in these adverse environments, whatever the form of adversity could be, develop a higher sensitivity to stress. And so what I'm showing here, I'm showing you two pictures where the size of the bar is the percentage of abnormal cortisol level. One of these pictures is about monkeys, the other one is about humans. And if I ask you which one is which, well, you will be surprised to see how similar are these biological reactions across the two different species. So you see that the two bars on the left are differences in stress reactivity between children born in orphanages and one born with natural parents. And the one on the right is the counterpart of biology of the differences in health that I show you about the monkeys. And so how these early environments, the experiences get under the skin? Well, what we have learned from the biology is actually children seem to be naturally wired to absorb all the experiences which come from the external system. So in a sense, it's our duty to protect them from this. And how does it happen? There are signaling pathways and receptors in our cells such that both adverse experiences come into the body and then they basically change the way the genes express themselves, and then they produce proteins, which basically they can change the way in which the biology of our body works, and these can get reflected back in the external environment. The good news is that if bad conditions can get under the skin, also good conditions can, so we can learn from the biology to design better interventions. And again, here I have another little bit of evidence, especially in the recent year, which shows that this social environment gets under the skin. In the previous years, there was a lot of talk from the environmental neuroscience about the effects on the brain of poverty and diversity. In the more recent years, there is a lot of talking about about the epigenetic and gene expression effects of the social and behavioral environment. And there are other biological pathways through which more evidence is building up to show how the environments affect the body, and then how can we, given this knowledge, how can we design better interventions to protect or to remediate this? So we don't know as much as we would like, but the evidence is building up, and so it's good to act upon it. And before I move to the early childhood interventions, I'm just gonna give one more slide about the biological effects of these environments, always from the monkey work. So you remember that the monkeys were reared by their mothers. They had these adverse physical and mental health effects, which were triggered through stress response pathways. What we found is that these very same monkeys also show differences at the more biological level, differences in gene expression, which means there was a change in the way genes were supposed to work, such that monkeys not reared with their mothers had bigger expression of genes involved in inflammation. So they had higher inflammatory response and a lower response to immune system, to viral attacks. And so this shows what happens, within the biology of the body, so that the external environment can actually manifest itself into long-lasting effects on health. We don't know how persistent these effects are, but it's something that we are currently investigating. Okay, so given all of this, what can we do? Well, what I'm gonna do, I'm gonna give you some evidence on interventions, and first about early interventions like the Abecedarian. So why early intervention, given all this knowledge, can be a promising avenue? Well, because we can do something when it's early enough that the body is very plastic, and you have all, the lifetime to reap the consequences. There are, of course, a few issues. Tom mentioned some of them. I'm sure that in the discussion after they will come up, so I'm not gonna talk about them right now. But I'm gonna talk about early childhood interventions. So the first one is the peri-preschool program. And the main point that I want to say about the peri-preschool program is basically the content of this program. And that's very important because knowing what they did to the kids is gonna tell you something about what were the inputs in terms of those investment and environments which affected some particular traits which then are causally related to some later outcomes. So in the peri-preschool program, the children stayed in a daycare center for 2.5 hours per day. And what they did there was basically some form of cognitive and behavioral stimulation. They stayed there and they went through a so-called plan, do, review routine. So they had to plan the task at the beginning of the day, do the task, and then review it at the end. There wasn't much else you could do in 2.5 hours. And so it doesn't take much to think that if you have to do that, you have to stick to do something and then to have to review it in front of your peers, then it's very likely that you develop some form of self-regulation, that you become very good at planning things and then doing them at the end. And this is exactly what happened. So when we went and looked at the health effects of the peri in the latest wave that we have available, which is age 40, what we found that the bigger health effects of the peri-preschool interventions were in terms of health behaviors, in particular smoking and also having a more nutritious diet. And so if you look there at the means of the treatment and the control group, basically the treated group of the PERI was both less likely to smoke at age 27 and 14, and if they were smokers, they were likely to smoke much less. And when we conducted some mediation analysis and looking at the mechanisms through which this intervention changed the smoking behaviors, if you look at the red part of those bars, most of the effects of the treatment is explained by changes in this self-regulatory capacity of the child. And if you remember, that's exactly the same trait that I showed you earlier on, which is related to changes in smoking behavior. So changes in these behavioral traits, intervention which can affect them, seem to be effective in changing healthy behaviors. What about the Abecedarian, which is the intervention Francis was involved with? Well, the first thing that we should notice is that the Abecedarian was actually much more intensive, long, and complex intervention. It not only had a stimulation component, but it also had a nutrition and a healthcare component. And I think this is really important to understand the effects that we find. So when we looked at this health data that they collected in the mid-30s, we found something absolutely striking. So if we look at the differences in health outcomes between the treated and the control, where you see that the treated is the blue bar and the control is the red, there are starking differences in the markers for cardiovascular and metabolic diseases. So that 1 in 4 individuals in the control group developed what is known as metabolic syndrome, while none in the treatment did that. And control individuals were also most likely to have a low level of the good HDL cholesterol, to have high blood pressure, and to have high abdominal obesity. And just to give you more details, you see that the effects were both in terms of diastolic and systolic blood pressure. There were starking differences in the prevalence of hypertension, vitamin D deficiency, but I think what is very important is that there were not only differences in single outcomes, so it was not that the treated were better in only one of them, but what is really important is that the cluster of health conditions which constitute the bulk of healthcare costs which are spent now was significantly lower prevalence in the treatment group. The treated were less likely to be obese and less likely to have high blood pressure and less likely to have low HDL cholesterol. And so if you look at those means there, you see that there was basically nobody in the treated group who had metabolic syndrome or this cluster of health conditions. And surprisingly enough, because these individuals were in their mid-30s, we also found that they had the lower prevalence of developing cardiovascular disease by looking at the Framingham Risk Index, which is an index predictive of this CVD risk. And so now the question is, of course, where did this come from? If we think in terms of our models, how these health effects were affected by this intervention, through which changes in traits. Was it IQ? Well, when we looked at it, it was actually not. So what could have been? So we had a look at the BMI of the child. So we started thinking what could be determinants of metabolic conditions later in life. Now, if we look at the BMI at birth, of course, the two densities are perfectly overlapping because there was no difference at the start. But already after 3 months since the start of the intervention, we started seeing some differences. So if you look at the solid line, that's the line for the treated group, and the dashed line is the control. Now let's look at what happens as we move through the Abecedarian intervention. So this is 6 months, this is 9 months, this is 12 months, 24 months. You see that the treated group of the Abecedarian intervention, the density of BMI is becoming less spread out and shifted to the left. So these kids have actually good BMI. The control, instead, the density is much more spread out, and there's this long right tail. They are getting overweight. And this continues until 36 months, 60 months, which is the last time when we have data for the end of the intervention. You see that the control group is actually this huge number of children who have above normal BMI. And we can look at this in another way. What is this plotting? This is the BMI z-score, where it's plotting across childhood for both the treated group, which is again the solid line, or the control group, which is the dashed line above. And you see that the treated group has a BMI which is on average at the median of the reference population. The control group has this huge jump soon after the start of the intervention, and they keep being above average BMI throughout their childhood until 8 years of age, which is the last time for which we have this data available. And then if we look at this in another perspective, if we look at the early life differences in BMI between those who were and who were not obese in the mid-30s, what we see, the solid line shows the early BMI of those who were not obese in adulthood, the dashed one of those who were obese. Well, those people who were obese in their mid-30s were already above normal BMI when they were children. And this is true again throughout their childhood. So this really tells you a lot about the origins of those late life differences and the power of this intervention. And so the last question is like, of course, so why do we see these health effects? The intervention did actually quite a lot. So which of those components, might have triggered those changes in adulthood? Was it the nutritional component, the healthcare component? Was the fact that the parents were informed about the power of nutrition? Well, we can't really disentangle over them. The thing that we can really say is that if we look at what explained the effects of the treatment in terms of most of the outcomes at age 35, that was the reduction in the BMI of the child among the treated group. That explained a huge proportion, more than 50% of the effects of the treatment. And now if I have time, I've got like 3 more slides on what we can do at a later point of the childhood, if you like, or in adolescence, in terms of late intervention, just because there's been a lot of talking about the effect of education on health. So if you look again at this into the life cycle developmental perspective, then what you can do later on, once you've done something later on, well, you can try to remediate something which went wrong, and the easiest way to think about this is that can you provide a similar form of enrichment by targeting biological systems which are still malleable? And if we think in terms of education, what we know in terms of malleability of the traits, we do know that some traits like behavioral traits are still malleable in adolescence, which is why there is some evidence that adolescent intervention works in improving the personality of the child. And so getting back to the picture that I showed you at the beginning, if we look at the effects of education on health, what we see is that disparities, some of them are explained by early life factors entirely. Like, for example, if you look at the bar which is in the middle, which is totally white, that the differences in obesity are explained by early life factors. And that's consistent with the evidence that we have from the Abecedarian intervention. If we consider differences in smoking behavior, we have seen that smoking is affected by these changes in behavioral traits, by self-regulation, to the extent these traits can still be changed during adolescence because the part of the body which are affecting those traits are still malleable. There is something which can still be done in adolescence for education and intervention. And the last thing is that, of course, the two things do not have to be seen in isolation because human capital is a cumulative process. And so there is always going to be an interaction between early and late investment because the two build on each other and they complement each other. And so if we look here at the effects of education as a function of these traits, which are enhanced by early intervention, what we see, this is the effect of education on the reduction of being a smoker. You see that the effect, if you look at the black line, the effect is bigger for the children who were more cognitively able, and the effect, on the other hand, is bigger for the children who had lower level of self-regulation. So if you look at the bottom left part of the blue line and the bottom right part of the black line. So why is that? Because if you think of what education is providing, education, if it's providing information on the danger of being a smoker, if you are more cognitive capacity, then you're better able to process that information. On the other hand, if you had lower self-regulation to start with, that trait is still malleable, so education can improve the trait, and you will see higher returns for the children who had lower value of those traits. And finally, the last thing is that today there's been also a lot of talking about 2 generations interventions, intervening of the parents and of the children at the time where biology is most amenable to change for each of them. So what have we learned after all this? We've learned that actually these disparities which emerge late in life are not only a function of late life circumstances, behaviors. At least a substantial part of them, and for some of them, the totality of them, can be explained by early life factors. We've also seen that what happened early in life can have long-term consequences. because experiences can affect the biology of the body. Now, of course, on the one hand, this is good news, but on the other hand, we can leverage on the malleability of this biological system, and we can intervene when they are most malleable. So when we provide enrichment interventions at critical periods, which provide inputs affecting those traits which can be changed, then we can see long-term consequences. And so I guess the lesson we can learn from this, by knowing when to intervene, we can actually use early life investment as a useful and effective mean to prevent disease and promote health. Thank you.
Thank you very much, Gabriella. All of you out there, you're not totally doomed, although it's getting a little dim if you didn't get an early start. But there's still hope for your children or your grandchildren. Remember that. Think about the kids. And that's one way of looking at this promising area. But what about everybody else? What about the folks who are bobbing around in the middle of a healthcare system which promises to do good, but sometimes the front end doesn't connect with the back end and all the pieces involved in it. Now we turn to our next speaker, Dr. Harold Freeman. We thought we might actually have a physician here on occasion. He's founder and president and CEO of the Harold P. Freeman Patient Navigation Institute in New York City, professor emeritus of surgery at Columbia University College of Physicians and Surgeons, and he is a true pioneer in the concept of patient navigation in its purest sense that focuses on patients, a program to provide low-income patients with personal guides through the healthcare system. Among his past and current roles, he's a diplomat of the American Board of Surgery, fellow of the American College of Surgeons. He served as president and CEO of North General Hospital in New York City. He was director of surgery at Harlem Hospital Center for 25 years, elected to the Institute of Medicine of the National Academy of Sciences, and served as national president of the American Cancer Society. He received an honor as the Mary Lasker Award for enlightening scientists and the public concerning the interrelationships between poverty, race, and cancer, and he's here to enlighten us further about the potential, the progress, and the application of patient navigation in its broader sense. Harold Freeman.
Thank you very much. I'm very happy to be here. And in reading the New York Times yesterday, I saw an article by Arthur Brooks, the head of this organization, who said that when you're happy, the left side of your cerebral cortex is more active. So I assume that mine is active this morning. I'm going to highlight an experience of about 40 years. I was trained as a surgeon, came to Harlem in 1967 as a cancer surgeon, and faced a population of women in particular who were coming in with very late breast cancer. Some of the women were coming in with ulcerated masses on the first visit. Bothered me a great deal. Frustrating because I had trained to a high level, ready now to cut cancer out of Harlem, in a way of speaking, but frustrated because the problem was deeply embedded in the human experience of the people in Harlem who were poor and black. So it led me to do certain things. The first thing I did was to find a way to screen the women free of charge if they could not pay for breast cancer, including mammography. And that did help. But it did not solve the problem. After all, mammograms do not cure breast cancer. Maybe you need a mammogram, but if you only have a mammogram and you're lost after that, you still have a serious problem. And so I had another experience. I got promoted to president of the American Cancer Society in 1989. And I had a chance to look at the whole country, sensitized by the experience that I had in Harlem with poor black people, but hearing the testimony of poor people of all races, white, black, Asian, Hispanic, Native American people testified. The people who testified were poor and also had cancer, a combination of poverty and a lethal disease at the same time. And out of those hearings, I got some guidance. The poor people who testified said, we meet barriers when we attempt to get into and through this very, very complex American healthcare system. We meet barriers. So that was a signal to me. They said other things. They said, we make sacrifices, we lose our jobs, we lose our insurance, we lose our dignity. They said the educational system in America, no matter where it's coming from, government or Cancer Society, is often insensitive and even irrelevant to us. They said we become fatalistic and we give up hope. So with that background of a local experience and a universal experience looking at the whole country, I came to a conclusion that we had to do something special in Harlem, and that was the origin of the concept of patient navigation. So in 1990, a year after those hearings, I started this program in Harlem with the idea of helping the people in that community, not with the idea of generalizing to the whole country. What I did was to bring people into Harlem Hospital that I called patient navigators. Put the navigators in the room with the doctors on initial examination in the breast clinic. And after the doctor made a recommendation, and our doctors always make a recommendation, the navigator would take the patient to a separate room and talk to them one-on-one, and ask questions such as, did you understand what the doctor just said to you? Often the patient did not understand. Communication barrier. Is there any barrier to your getting the biopsy which the doctor has recommended? I have no health insurance, okay, typically. So we have to find a way to get a person covered. The navigator had to do that. Sometimes the patient would say, I'm simply afraid and I don't trust these doctors or this hospital. So the navigator would intervene in that as well. Sometimes the patient would indicate the healthcare system is so complex and I can't really find my way. It's too fragmented, so to speak. Navigator would help. So we put navigators as personal guides to solve and eliminate barriers to timely movement through the healthcare system. And ultimately, we proved that it worked. The evidence of the proof is that before screening and navigation in Harlem, at Harlem Hospital, looking at 606 consecutive patients who came into Harlem Hospital with breast cancer, the 5-year survival rate was 39% before intervention. After screening and navigation, the 5-year survival was 70%. So something we'd done had worked. And this was still a local situation at this point, but it seemed to be an idea that had some meaning. So the question is, can you, through personal guidance of people, help them through the healthcare system? And the measure of success then is timeliness of movement through the system and also quality of care. So I began to know that there's a difference between what I call patient navigation, which is the movement through the whole continuum from a beginning point to an end point. And in Harlem, we started at the point of abnormal finding to the point of resolution. Resolution could be a finding, a diagnosis was benign, so navigation is over at that point, or navigation if the patient has cancer, now we have to navigate them to the end of treatment. So we focus on that window of opportunity between finding and resolution. We showed by actual research and publication that we changed the outcome from patient population presenting with only 6% early disease to 41% early disease, and changed the 5-year survival from 39% to 70%. I had the opportunity to present this with a lot of other help to the political system in America, to the Congress, and ultimately to the President of the United States, George Bush, in 2005, signed what was called the Patient Navigation Act in 2005, which gave funds to support demonstration of patient navigation. So that's the story. Let me go to a few slides that I have here. My sense is that there are 3 elements that drive disparities, whether people have resources, a circle of poverty, or not. how people behave, the circle of culture, and whether people have been treated fairly or not, the circle of social injustice. And these overlap and drive disparities from prevention, detection, diagnosis, treatment, to end of life, the healthcare continuum. And that's a theory that I'm living by. Another way to look at this, poverty causes negative events, that's for sure. And looking at these boxes that I have before you, poverty causes people to have inadequate social support, less knowledge, tendency toward a risk-promoting lifestyle, and the fourth box, diminished access to care, particularly to preventive care. The healthcare system itself, as we have devised it in the world and in Americans, does not deal with all of these boxes. It deals with the fourth box. So we talk about access to care, but access to care among poor people occurs in a broader context. The same people with low access to care have low knowledge and less social support. And so something has to be done, I think, to address not just access to care, but the broader context of low knowledge and even early things that you've talked about here before. So the concept has come out of this issue. So where does culture fit into this? In my view, culture becomes a prism through which poverty operates. Let me explain. So to the extent that people are in a certain culture, such as the Seventh-day Adventists, do not smoke cigarettes, eat vegetables, and don't drink alcohol, a culture like that, even when they're poor, they won't develop lung cancer very much or other diseases. The culture in Harlem that I was facing over 40 years, a culture that smoked heavily, ate the wrong foods, drank alcohol, and had a very negative culture. The same occurred in Appalachia. I compared Harlem, New York with Harlan, Kentucky, for example. And so the issue was not race in itself, the issue was behavior, and that's an important distinction to make. And so I think this kind of outlines, if this is true, then you could think of, so what then should be the solutions to this kind of problem? The findings I've gone over from the American Cancer Society there, I won't go through them again. The Harlem experience, I'll just outline briefly for you. Stage of disease in Harlem. Before intervention, only 6% of women, of 600 women had early breast cancer, and half of them had late breast cancer, and the 5-year survival rate, 39%. This is at a time when the 5-year survival rate in America was 75%. In Harlem, we're seeing 39%. Something wrong, something very wrong. After we did two things, screened the population for breast cancer free of charge if they could not pay, and assured that people with findings were rapidly navigated to diagnosis and through treatment, which is navigation. Results changed to 70% 5-year survival, and this was published and presented to the political system. And here is the patient navigation model that we first started from point of finding, the yellow line on your left, and to resolution, the yellow line on your right. And here's the President of the United States in the Oval Office signing the Patient Navigation Act from the work that came out of Harlem in 2005. We then thought of a broader model, so if we were concentrating on from finding to resolution, as I showed before, we felt that the healthcare continuum, which is at the bottom, prevention all the way to the end of life, people could be navigated across the whole system. Therefore, you create outreach navigation, bringing people from where they live to a healthcare site for particular examinations. And then we could create navigators that work with diagnosis from finding to diagnosis, diagnostic navigation. We developed treatment navigation, treating people who have a diagnosis all the way through treatment. And then the idea of survivorship navigation. And so this is the current theory that we have now, applying navigation across the entire healthcare continuum. And so the question then, who should navigate, comes as a question. Let me say that it's an analogy that I would give you as the mile relay. I'll just take a moment to say what this analogy is. So a mile relay, there are 4 runners. There's a starting point and there's an end point. And the race is not over until you cross the end point. In surgery, I learned that early, when we operate on people, we have to open, we also have to close. So that's kind of philosophy that I've kind of lived by. And so the navigation concept, you open it up, but you also have to close. There's an end point to be considered. But there also are 4 runners carrying a baton. I want you to imagine that the patient is the baton. So the first runner, who has certain skills and tasks, carries the baton and passes it to a second runner, who may be a different skilled person. And finally, the 4th runner carries the baton across the finish line. You cannot drop the baton in a real race, or you will lose the race, and nor can you drop the patient. So we need to have a connection of the whole race. So navigators then carry out phases of the race. Navigation is the whole race. In order for this to be successful, there has to be a coach. You won't win an Olympic mile relay unless you have a good coach coordinating the whole movement. That's an analogy that describes my plan. Principles of navigation, what are they? Briefly, navigation is patient-centric. So it's an individual approach, guiding individual people through the system. Now, we tend to specialize in whatever. The more educated you are, the more of a specialist you become. And that could lead to what, Tom, you mentioned as silos, and that does occur. And that's something to think about. I became a highly trained surgeon, for example, and I could have kept doing highly trained surgical work on late disease, I would have had no improvement of results. So you have to be specialized, but you have to step out of specialization to look at the whole picture, and that's an important point. Navigation fundamentally is designed to eliminate barriers to timely care, financial barriers, communication barriers, system barriers, barriers related to fear and distrust, barriers related to transportation, barriers related to children at home alone. Whatever the barrier is, navigators should solve that. And navigation, another way to look at this, can virtually integrate a fragmented healthcare system. For example, if a patient with a complex disease such as cancer, which is an area where I have worked, has to go to 4 or 5 different sites which are disconnected, and this is often the case, to get treated. You go to a doctor's office, you have to go to radiology, chemotherapy, surgery, social service, whatever. To the patient, this is very, very difficult. But a navigator can plot the course and connect the dots for the patient and plan the movement of the patient through a fragmented system. So virtual integration is something that navigators can do. Patient navigation, if you set it up anywhere, you need to define what it is. If you don't do it, there'll be confusion. And you need to say when navigation begins and when it ends. Who should navigate should be decided by the level of navigation that you're undertaking. In the programs that I have developed, we have used lay people, who cost much less money, by the way. And because the problems we were solving in Harlem had to do with, did people have health insurance? Did they understand what the doctor said? Could you guide them through a complex system? Was there fear and distrust? So those problems can be solved by people who are non-professional. And that was the weight of what we did was done by lay navigators. At a certain point, you could create navigators that need to have medical knowledge. For example, in prostate screening, which we have done much of, there's a blood test, and it's something, the PSA is elevated. We can't have a layperson explain what it means to have an elevated PSA. You go to a doctor, you get a needle biopsy, it comes back Gleason 7. You can't have a layperson explain it. It has to be somebody with a medical knowledge, generally a nurse. The options for treatment may be complex, watchful waiting, radical surgery, forms of radiation cannot be explained by a layperson. You have to bring the medical system in. So the team for navigation should include select people according to the job that you're trying to do. Lay people on teams with professional people, moving people through the system, concentrating on the movement of the patient, which is different from concentrating on creating a good system of care. Both need to be done. And so, to move on, navigation can also, I find, help people to go across systems of care. Most care in America and anywhere else is given in a primary care system. And the primary care system can carry the patient to a certain point. But when it's a tertiary problem, the patient has to go from primary care to tertiary care. That is often a challenge. But we find that if you put navigators in the primary care system and navigators in the hospital system and connect the navigators, you can in fact connect primary care to tertiary care. And finally, as I said before, navigators need to be coordinated, some leadership to guide a navigation program. Let me go to some research findings to add some meat to this. So the most important study so far that has been done on patient navigation was not the study that I did in Harlem that led to this, but it was a study done by the National Cancer Institute between 2005 and 2010, a 5-year period. The National Cancer Institute created something called the Patient Navigation Research Program. I'm going to tell you what that program was. The program was testing whether it is a benefit to the patient to navigate from the point of abnormal finding to the point of diagnosis of cancer. And it was set up at 7 different sites around the country to show whether or not navigation can improve the timeliness of movement from finding to diagnosis and into treatment. 6 out of 7 of the studies showed a positive effect, and some of the effects were very positive, some were moderately positive. So we conclude that from that study, where the government spent $25 million to do this, and it's now concluded and published, that navigation can diminish the time in a poor population from point of finding to beginning of treatment. So that, and that's a very important thing to accomplish. Previous research had already shown that navigation can increase the number of poor people who are screened at all. So when you put together 2 sets of findings, the review of literature in 2011 of all previous publications, which were 44 publications by 2011 that were reviewed that met the criteria for research, and that research concluded that navigation can dramatically increase the number of people who are screened at all in the poor population. And the studies from the NCI showed that navigation can diminish the time from finding to diagnosis. So this, if you can do this with poor populations, you can increase the number of people who get treated early. And the effect of this, I think, in the long run, would be to save money. Because if you treat poor people late, which is what I faced in Harlem when I went there, you have to pay for that. You cannot not pay for the treatment of late disease. You will pay for it. The society will pay. If you spend some money, what you said, up front rather than in the back, Tom, I think you mentioned that concept of the back versus front, spending some money up front to get people into the system early and treated early will ultimately save money. So the major findings. 2011, a review of all the literature showed increase in the number of people who are poor who get screened at all. The National Cancer Institute Patient Navigation Program I'm going to summarize briefly here with studies that came out of Denver, Boston, Chicago, Ohio, and San Antonio, basically showed the weight of evidence that patient navigation diminishes the time from finding to diagnosis and treatment in breast cancer, colon cancer, cervix cancer, and prostate cancer. The Boston study. There was a study in Washington, D.C., by the way, which was in breast cancer and showed a very huge effect in reducing the time of when women in Washington, D.C., who had findings of breast abnormalities to the point of treatment. I won't go deeply into these studies, but, and so let me conclude with some generalizations. In 1967, some nearly 45 years ago, I was faced with a problem of late diagnosis of breast cancer and high death rate in women with breast cancer in Harlem. By applying patient navigation, which was a system in which we assured that people with findings were rapidly diagnosed and treated, we reduced the death rate significantly. We had an opportunity to argue this case in a political system, and now the current status is this. The American College of Surgeons last year determined that patient navigation is a standard of care which must be applied to all cancer centers which to meet the inspection of the college. This is about 1,500 cancer centers in America that next year will have to meet the standard. The Affordable Care Act requires that patient navigators be used to assist uninsured people into the exchanges into insurance, and that is going on right now. So these are some of the things that have happened. Let me generalize and end my talk. I think that my own experience is summarized in three ways. I came to Harlem as a surgeon, operating on individual people, and I think that's important. I faced a population of people who were poor and black. It made me look deeply into the meaning of what does it mean to be poor, and what does it mean to be black, and what does it mean to be black and poor in America. And that led to national hearings that I described to you. So I went from a surgeon to a person who tried to understand a population system, and now back to individual concern. So I've had a peculiar transition, operating on individual people, trying to understand the population, and finally believing that finally you have to help individual people. You can't cure a population, you have to cure individual people. And I've learned that. And so, so where do we get this energy? So in every community in America and elsewhere, there's a lot of energy to be harnessed. And we have to find ways to harness human energy. And this will be at lower cost because the energy is there if you know how to harness it. So I believe that patient navigation is a method of harnessing human energy. A lot of people are born to help. Some want to volunteer, others need to be paid. So patient navigation is a way of harnessing human energy, directing it specifically to help people who are disadvantaged to get through a complex healthcare system. And so I'm going to end my remarks there. This thing is still emerging. It appears that the concept of personalized guidance of people through the system is gaining a lot of weight in the country as a whole. I think in the end, it not only will be a human benefit, but it will be a cost-saving benefit. Thank you very much.
Thank you very much, Dr. Freeman. Our final speaker is Barak Richmond. He's the Edgar P. and Elizabeth C. Bartlett Professor of Law and Professor of Business Administration at Duke Law School. He researches the economics of contracting, new institutional economics, antitrust, and healthcare policy. More notably, I first met Barak in connection with a symposium where he co-edited with Clark Havighurst a volume on who pays, who benefits, distributional issues in healthcare. You've got one of a related article on behavioral economics and health policy, understanding Medicaid's failure. You only could do that in only 66 pages. I thought you could write several hundred on that one.
It should have been 3 articles.
That's right. Barak has a book coming out, I'll give you the plug, Stateless Commerce, to be published by Harvard University Press next year. Is that covered under Article 1, Section 8? Would it be interstate if it's stateless and subject to congressional regulation, or outside the bounds?
Depends on if we're talking about this court or a future court.
Okay, well, it could be a 5-4 decision in any case. His recent work is even included challenging illegal practices by rabbinical associations. There was a New York Times article on that. He's on the health sector management faculty at Duke's Fuqua School of Business and is a senior fellow at the Kennan Institute for Ethics. He won an award at Duke for Teacher of the Year in 2010. Apparently that's a more competitive category than when I was at the law school. Things have improved on that front. In any case, I don't know what Barak's going to talk about today exactly, but we know that what he's going to say will be refreshing, thoughtful, and important. Barak Richmond.
All right, thanks, Tom. Let's hope I can live up to that. I first genuinely want to begin by expressing my admiration for the other people on the table up here. I have enormous admiration for Tom for organizing this and for his opening remarks, which really is not just how he talks, but is also what he really tries to do. Pushing beyond conventional partisan thinking, pushing beyond partisan divides. And when we think about something as complicated as our national health system, or specifically the health of our national population, it is very, very refreshing to try to push beyond conventional wisdom and to at least aspirationally push towards some kind of bipartisan thinking, really forcing the policy world to think hard and to synthesize the science. And I am enormously grateful to be part of that. So I admire Tom an enormous amount for that. I also additionally admire the 3 scholars up here. Dr. Campbell's work in the Abecedarian project is, to say it's seminal, is an understatement. It's extremely important. I became familiar with Gabrielle's work through her co-author, James Heckman. I'm an economist, and it was through that back door that I realized exactly how valuable this work that she does is. And I've been, and not just myself, but many of my students have been an enormous admirer of Dr. Freeman, the kind of work that he's been doing in Harlem, and the kind of thinking and leadership that he's shown in the national healthcare policy. So it's an honor to be up here. And my role is really limited, and I won't take a lot of time doing it. My job up here is really to try to close the envelope. Tom set this up by saying, we have all these policy questions. They very rarely get a lot of thoughtful scrutiny, but it's time to really, that's time, it's been time for a long time. But we really, there's a lot of opportunity to synthesize what these people up here have been doing and synthesize them into lessons for healthcare policy. So these scientists up here have done the heavy lifting. I will do at least a little bit to try to relate their findings to certain policy implications. The objective really is to try to illustrate, because it's obviously relevant, but try to illustrate the specific applications to this policy community. There's a reason that this conversation is happening here in Washington. And my small role will be to try to highlight some specific policy issues that are significantly and deeply informed by the kind of research that the scientists up here have developed. Just reiterating, I don't want to spend a lot of time on this, but reiterating what Tom said, we are really trying to encourage this entire community here, the policy community, to think about this, to think about it in a nonpartisan way, to focus our priorities. It's not on funding programs, but on improving population health, and understanding that although the right answer is elusive, there are some answers that are more right than others. And it's hard. It's very hard. So the more that this community can really scrutinize and think about these issues, the more there are some very significant opportunities to improve national healthcare policy. So I think I have three categories of observations. Again, these are all ways of trying to synthesize what our speakers have identified into specific policy applications. And I'm going to go, there's an easy way to do things and a hard way to do things. I'll go in order of, with ascending complexity and ascending difficulty. So I'll start with the easy ones first. So there is an overwhelming theme that in the importance of early intervention and comprehensive intervention. We know that it's important to try to develop cognitive development early as opposed to later. It's important to think about this as it relates to health inputs, that early intervention is both more effective and less costly than later intervention. So one obvious application there are a certain number of programs that might enhance cognitive development. If we think about this from we'll say a budget neutral perspective, we will certainly make the observation that we spend a lot of money on Medicare and not nearly as much money on early intervention. So if we think about the value of a particular dollar input, there is a lot of evidence to suggest that we're investing at the wrong life stage, and dollars can be better used. Similarly, related to this early intervention theme and comprehensive intervention theme, specifically as it relates to cancer, certainly early intervention is less costly and has better outcomes. But to a large degree, we still have a fee-for-service reimbursement system, which means that providers, if they are profit maximizing, I'm not saying they are, but if they were profit maximizing, they would be much more enthusiastic about later interventions with costly surgical procedures rather than early interventions with biopsies. There is a lot of money spent on complicated chemotherapies that could be a lot less costly with early intervention. So how do we encourage early intervention? Well, one way certainly is what Dr. Friedman has done. We try to nationalize a navigator system. We simply decide that that investing in navigators is a more cost-effective intervention than later interventions for patients with cancer. We could also try to think about this through the lens of incentives, bundled payments, for example. You don't want to be overly general about the efficacy of bundled payments, but in the system, within the framework of treating cancer payments, it makes a lot of sense. Where early intervention truly is less costly, and if there's a way to incentivize providers to seek out patients early and to give them some kind of flat fee, that would encourage early intervention. So there might be ways to incorporate these lessons into the reimbursement system. And there might be some market-oriented approaches to trying to figure out how to incentivize or induce early intervention. So that's the easy stuff. We think about reinvesting dollars or reallocating dollars. Earlier is better than later. Detection and early treatment is better than later treatment. There are ways to do that through public dollars. There might be ways to reorient programs and reorient regulations to encourage private parties to do those things. The second category of observations has to do with this theme of silos. We understand here that health consequences, that is the outcome of interest, health, is not merely a function of health inputs or medical inputs. Very much to the contrary. There are inputs that are non-medical. There are social inputs. Education is an enormous input in producing good health. So it makes a lot of sense to break out of these silos, to think about health policy not as being administered primarily through CMS, and health care, you might say, or health services not being delivered primarily through healthcare providers, licensed providers, but thinking a little bit more comprehensively about how we can use policy dollars to embrace this more comprehensive and holistic approach to understanding how we can improve individual health. One specific example is the Medicaid waivers. The Medicaid program itself has a lot of inherent built-in flexibility, but a lot of that flexibility has yet to be really capitalized upon. We don't need to, we're not constrained to use Medicaid dollars through conventional healthcare providers. Navigators, I think, would be an appropriate use of Medicaid dollars. In fact, actually, you could even think of a navigation-based system being a central part of a state's Medicaid system. Similarly, and I think profoundly, we think of only our national healthcare system being delivered through our Department of HHS, whereas really it's possible that the Department of Education influences our national health more. There is a very unnatural division between education policy and health policy, much like I think there's an unnatural division between how we allocate or deliver our healthcare system. The schools really are not an instrument in that at all. We should, as we think, it would be nice to reorient the education department to not just care about test scores, but to care about health outcomes also. And there's nothing wrong with encouraging that mandate and having our educational policies, state and federal, to think about health as a desirable outcome as well. And similarly, if we want to think about how CMS, through the Medicaid program, can improve health outcomes, it should embrace educational approaches also through educational providers. So the second lesson, if the first lesson is the value of early intervention and allocating at early stages, the second lesson is we need to think about these things more comprehensively, and our policy instruments are not comprehensive. They are the opposite. They are siloed. And there is, the current law allows for a lot of flexibility that we haven't capitalizing on. And the research by these scholars have suggested that thinking comprehensively outside the silos, thinking flexibly and creatively, would be a very, very valuable thing. The third observation is the most profound in the sense that it's the most difficult. But in the spirit of bipartisanship, I will quote a Tar Heel, Bill Roper, who I believe is still chancellor of the UNC healthcare system, put it really beautifully. He says, our healthcare system gives the wrong care, I want to get this right, gives the wrong care in the wrong places by the wrong people. We are, the way we deliver healthcare is really not natural to what our patients need through healthcare. Now, we have talked about how we need an individualized approach, how we need a patient-centered approach. A lot of that involves trying to reduce complexity. A lot of that is directly handled through navigation, but I think that really is should be the beginning of our thinking very critically about how we structure our national healthcare system and how we think about health. I think there's a lot of evidence up here to suggest that health is a much more organic experience than a technical one. It is benefited through a bottom-up approach rather than a top-down approach. It is not like delivering water, where it's purely a matter of pure technicality and is the same everywhere. It is something that needs to be sensitive to environment, to social organizations, and to other sorts of organic formations that really could do better than our top-down approach. And when I say top-down, I mean top-down in two ways. Number one, it is a very, as opposed to a patient-centered approach, it is a very provider-centered approach. You need to go to where the provider is, and often you need to go to where the multiple providers are. It is about reimbursement for services. It's not about looking at what the particular patient's needs are. But also, not just is it a provider-centered approach, but also is an approach that is predominantly reliant on providing health insurance. The way Washington and states, the way we think about mitigating health disparities or improving a particular health outcome is saying, well, let's cover it. Let's cover particular services that can address that condition. And that approach is very insensitive to both the complexities of translating healthcare services into health, but also very insensitive to the complexities of seeking healthcare to begin with. A bottom-up approach would be sensitive to those a lot more. What would that look like? Well, certainly we might want to rethink the professional organization of our healthcare system instead of only reimbursing for services provided by medical professionals. We want to think outside that. We want to think about navigators. We want to think about social workers. We want to think about, all the people that make us healthier. At the risk of sounding implausible, we want to think about the health coaches. We want to think about people that really are trained to change behavior and decisions. With all due respect, surgeons generally don't do that, but a lot of other people do. And they should be a central component to our national healthcare strategy. Similarly, we should think about how we deliver healthcare, not just through complicated academic healthcare centers or other sorts of hospitals, but through different social organizations. One real challenge with our formation of ACOs, accountable care organizations, is that many of them are hospital-based. That is doing little more than reinforcing our current delivery system. And think about other kinds of ACOs, certainly insurance-based ACOs, where there is more focus on individuals, but think about other sorts of ACOs. What if social workers formed ACOs and really tried to intervene at the decision-making level and help patients shop intelligently and navigate intelligently? There probably are enormous savings. And if social workers could really intervene at that level, I think they would be significant beneficiaries of the shared savings program. We can think about churches. We can think about schools. These are natural social organizations that are very in tune with the healthcare decisions, and I think very attuned to the health status of their members. They also could really, could fruitfully intervene in how individuals consume care, how they shop for care, and what kind of care they need. And lastly, we want to think about our economic organization. So professional organization, social organization, and economic organization. There should be lots of profit opportunities. If we're spending 18% of our GDP on healthcare, and we still, to use OECD comparisons, are no healthier than nations that spend half that much, that's a lot of money on the table. And if there are ways that entrepreneurs can tap into these valuable features, whether it's through navigation, whether it's through early intervention, other ways of trying to improve outcomes through non-traditional ways and saving money, there should be enormous economic opportunities for that. That will require rethinking a lot of licensure laws state by state. It might require rethinking some of the shared savings rules. But there is enormous potential out there, not just for policymakers, not just for providers, but also for entrepreneurs. The bottom line is these lessons are enormously valuable. They have some specific applications, but they also challenge a lot of our foundational assumptions about the healthcare system. And we in Washington, policymakers, should be thinking about this. So I'm delighted to be a part of that.
Thank you very much, Barack. I was drawing upon my cognitive reserves. I understand that it'll keep me from having an early onset of Alzheimer's if I've built up enough in my head. So that's another back-end reward for all the front-end things that you load into your base. They've been talking, I think, even about pediatricians issuing prescriptions of saying, read your child a book and call me back in a couple of weeks, as other ways to extend the bounds of this. A different trifecta, focusing a bit more perhaps on the health disparities than the broad-based health outcomes end, might be to say the reason why we need to do this is, first of all, because it's right, it's just. But secondly, it works. And third, oh yes, it also saves money. That's pretty good to get that in a package if you think about not being wedded to the same means in order to achieve the ends we say we're all about. We've got about 15 to 30 minutes, depending upon the level of interest in questions from the audience. We'd welcome your comments in the form of verbal op-eds, but preferably questions to our speakers. We've got a question right there. If you could identify yourself before your question.
I'm Dr. Caroline Poplin. I'm a primary care physician. I'm delighted to hear this panel. It seems to me that the logical conclusion from the earlier presentations about early childhood intervention, or very early childhood intervention, is a kind of European system where they have paid family leave, the provision of childcare, extensive childcare that's available to everyone. I think that's what they have in France. And I think that much more robust social services in general in Europe is one reason they get better outcomes for less money.
Stand on its own terms. Any other further questions or comments? Back in there.
A question, not a comment. Lauren Semenuk from Novo Nordisk Pharmaceutical, specializing in diabetes. When I hear your successful interventions, be it both healthcare and education, what smacks me in the head is how did you, or how would you get by the Congressional Budget Office that doesn't recognize generally the scoring, of prevention? Like Dr. Freeman, how did your bill get through CBO? I mean, we have in diabetes, there are lots of successful evidence-proven examples of averting the onset of diabetes, but that's always what our barrier is, CBO.
So the question is, how did the bill get through the Congress? Surprise to me, actually. It took a lot of people coming together. The American Cancer Society, for example, and others helped to present this to the Congress. There was a particular Congressman Menendez, who's now a senator, and a Republican woman whose name I forget, from Ohio, who came together, bipartisan, and they both were very sensitive to these issues of poor people dying. And I got to meet with them, and I think it was Menendez and the Republican from Ohio, whose name I don't remember, that got this into some kind of dialogue in the Congress. And as people began to see the point that through something that was not costing much money, the use of people in communities to help people in their own communities to get through the healthcare system in a defined way, particularly from the point of abnormal finding to resolution, began to catch on among many of the Congress people, and on both sides. In fact, I got as much support from either side. Democrat, it wasn't an issue of partisanship, the issue of understanding that poor people are dying at a high rate, and there may be some solution that involves harnessing the energy in the community. So it got onto the plate. The first time it got discussed, it didn't pass. About 3 years later, it did. So it was a gradual gathering of support, and I think that it was the logic of it that made sense. That the point, if you're even thinking only of a financial issue, you have to pay for people who are dying of cancer. In the end, you pay more money for advanced disease, and then people also die. So the idea of shifting the energy toward the front end, where you get people in for early diagnosis and treatment, seemed to catch on among the senators and the congressmen, and ultimately got all the way to the White House.
We have the perennial problem of, so how are we going to pay for this, and what's it going to come from, and what's it going to look like? One idea is to start in more discrete bites. That's why you don't universalize what seems like a good idea and say it's a gigantic program and we'll just find some more room on the credit card to do it. To some extent, you may have to substitute on that, but there are also targets of opportunity. You look at things that are not as much national, but are more community-based, within perhaps the Medicaid or the social services context. You can do all kinds of things locally with redefining how child welfare services are implemented and administered at a state and a local level. You can think of two generational programs which begin to work with the younger parents who have already had their problems, but you intervene with them to teach them the skills to first have a job and maintain a job, but also begin to parent their children better. These are soft, touchy-feely things that, if you do them sensitively at the community level, can have a large impact where they're operating without necessarily someone going on a press conference in Washington and say, I've passed the following bill, and here's the amount of money that's being dispersed. And since we always need an acronym in order to get anything done in Washington, I will suggest ABGs, accountable block grants, where you give the money out, but you actually have to have some metrics in order to produce, or you'll get less money or have to give some of it back and distribute it in that manner. So that might bypass some of the standard paradigm of, well, CBO on a mega level says this doesn't look like it's a wash, which is the way you always score these things, because there's not the evidence until you've done it. So you have to build the evidence in smaller bites. You have another question or comment? Go ahead, Mark.
Just very briefly to add to that. I mean, in many respects, actually, those two questions are two sides of the same coin. There are lots of ways to, there's a lot of ways to spend money in wiser ways. One might be from the top down. Yeah, I'm certainly a fan of a lot of what European investments do. That is one approach, and that would require quite significantly going through the congressional budgetary process. But the other way, I mean, a middle way, is these accountable block grants, which I think is a great idea also. Essentially saying, look, you know, we're giving you so much money for health and education, here's the money, go ahead, do it creatively, but make sure that you show some kind of improvement from the way that you otherwise would have spent it. But the third, and this is, I think, the way the healthcare system is going, at least conceptually, if not actually, is through things like the shared savings program and through things like bundled payments. And that really does not require, has not required, will not necessarily require additional congressional approval. And the basic idea there is, look, if you, again, this is the idea, not actually how it's playing out, if you assume responsibility for a certain population, and if you show ways of improving health outcomes while saving dollars, the money's yours, or at least part of it. Conceptually, I think that makes a lot of sense, especially because healthcare is such a social construct. It's so sensitive to individual and social influences. It makes a lot of sense to have smaller populations, smaller organizations assuming responsibility for small populations, and trying to think intelligently about what their healthcare needs are. So we kind of have the conceptual framework. To some degree, we have a little bit of policy out there that's trying to do that, and I think that that's the direction we can go into farther. And I think that where your question originated from, thinking about the population with chronic diseases, certainly thinking about diabetes is a very, very useful application of these ideas.
I think we've exhausted our time limits. I want to thank you for thinking about these issues. We know a lot about what doesn't work or doesn't work well enough. We ought to start thinking about what could work differently and work better and build on that. Please thank our speakers today.